Welcome back to The Deep Dive, your evidence-based edge for plastics in practice. Today we're tackling a really high-stakes topic, the acute management of severe lower extremity trauma. We're zeroing in on the evidence you need.
That's right. We're distilling the key decision points, assessment, timing, reconstruction choices. Think surgical pearls for your next trauma call, and definitely useful for MOC prep.
Okay, let's frame this. Imagine a 25-year-old guy. High-energy mechanism, looks like a Gustilo grade 3B fracture, distal third of the tibia, big open wound. Where do we even start?
It's the toughest initial call, right? Salvage or primary amputation. And we all learned those scores, the LES lower extremity injury severity scores.
Yeah, but standing there in the trauma bay, looking at that limb, can you actually hang your hat on a score to make that decision?
Well, that's the critical point. The literature, looking across several scoring systems, basically says they have a pretty limited usefulness. They absolutely cannot be the only reason you decided to amputate.
So the scores are just a piece of the puzzle, not the whole picture.
Exactly. Clinical judgment is paramount. The scores themselves, they're only validated at a diagnosis level for evidence level, not exactly rock solid for such a life-altering decision.
That's a huge takeaway for residents. Use the score cautiously, integrate it, but don't treat it as a hard cutoff.
Precisely. So if the scores aren't definitive, we immediately pivot to the most critical factor, the vascular status.
Right. What's the best evidence say about diagnosing vascular injury when you need surgical planning info?
The standard is clear, and this is level 1 evidence for diagnosis. Intraoperative angiography is the criterion standard, period.
Intraoperative, not pre-op.
Not necessarily. High-quality data shows that things like duplex scans or even formal pre-op angiograms don't consistently predict vessel suitability better than looking directly during the operation.
Okay, so that changes the workflow. If you're suspicious or, say, a distal pulse is out, you shouldn't be delaying the OR for outside imaging that might not even be accurate.
That's the implication. And there's a specific warning in the literature, too. This is therapy level 4 evidence. Only get that pre-op angiogram if both pedal pulses are truly absent.
Why only then?
Because they found cases where patients had normal pre-op angiograms, but intraoperatively, the vessels just weren't suitable for microvascular reconstruction. So the pre-op scan gave false reassurance.
Wow. Okay, so you absolutely have to be ready to make the final vascular call in the OR.
You do. Time is tissue. Time is limb.
Which brings us neatly to the next big debate. Timing of coverage.
Yeah.
Godina's famous recommendation.
Yes, Godina 1986. The classic paper. Recommended flap coverage for Gustilo 3B and 3C within 3 days, under 72 hours.
Why so strict?
To avoid higher rates of infection and flap loss, that really set the standard for a long time.
But things are different now. We have VAC therapy, negative pressure wound therapy, microsurgery is more common, skills are better. Does that 72-hour window still hold? Is it a hard stop?
It's more complicated now. The evidence is kind of mixed, or maybe nuanced is a better word.
How so?
Well, you've got studies like Hertel and colleagues, therapy level 3 evidence, that still support early closure. They found the group treated immediately had faster time to weight bearing, faster union, fewer infections.
So definite functional advantages to going early if the situation allows.
Yes, if you can do it safely and effectively, early seems better functionally.
But what if you can't? What if our patient needs other specialists? Or our time isn't immediately available? Is it game over for the limb if you pass 72 hours?
Not necessarily, and that's where studies like the one by Karanas come in. They showed really good success, actually. 0 flap loss with free flaps done well after 72 hours.
And the key difference was?
They used VAC therapy as a bridge. This is therapy level 4 evidence suggesting the VAC can buy you time, provided the wound is managed properly.
Okay, so the surgical decision-making pearl here is aim for early closure for potentially better function, but VAC can be a safe bridge if delays are unavoidable.
A safe bridge, yes, but, and this is critical, especially for board prep, you have to be really careful how you use the VAC.
What's the caveat?
It should only be used on relatively small, clean wounds where you have exposed bone, tendon, or hardware. Level 5 evidence basically says never put a VAC over a contaminated wound or dead tissue.
Because it just seals in the bad stuff.
Exactly. It can actually drive infection deeper if the wound isn't properly debrided first. It optimizes a clean wound bed. It doesn't create one.
Got it. Debridement first. Always. So let's say we've done that. The patient's stable, fracture stabilized. Now we reconstruct. Basic principle still applies. Bone first.
Absolutely. Fracture stability and reduction first. Then soft tissue. And for these complex distal third injuries, like our case example, free tissue transfer is really the workhorse.
Still the gold standard for that zone.
It is. The success rate is incredibly high, around 95% in acute wounds. That's solid therapy level 4 evidence.
We all know the classic ladder, or maybe zone approach.
Yeah.
Gastroc for proximal, soleus for middle, free flap for distal third defects. But that distal zone, finding good recipient vessels can be tricky after trauma.
It definitely can be. Vessels can be damaged, thrombosed, or just in the zone of injury. This is where advanced techniques come in.
Like what?
Well, if the local vessels aren't usable, you might need to find recipient vessels further away or create a way to bridge the gap. Cavada's published a large series, again, therapy level 4 evidence, showing that using arteriovenous loops is safe and reliable.
To basically lengthen the leash on your free flap pedicle.
Exactly. It gives you options when the local vascular situation is bad, a key technical pearl for complex reconstructions.
Okay, before we move on from flaps, what about local options for the distal third? The reverse sural artery flap comes up a lot. Seems less morbid than a free flap donor site.
It seems attractive, yes. It's a fasciocutaneous flap, spares muscle,
Yeah.
but the reliability, that's where you need caution.
How cautious?
Very cautious, particularly depending on the patient. There's data based on a senior author's large experience citing a really concerning 36% necrosis rate.
36%, that's alarming. That's more than 1 in 3 failing.
It is. And the risk isn't evenly spread. This is risk level 2 evidence. The danger zone is patients over 40, or anyone with significant medical comorbidities like diabetes or vascular disease.
So for that group, the sural flap is maybe not the best first choice.
You'd have to think very carefully, maybe consider a surgical delay procedure to try and improve its chances, or, honestly, maybe just move straight to a free flap, which we know is more reliable overall.
Good warning. Let's switch to another workhorse flap. The ALT, the anterolateral thigh flap. Use it everywhere for soft tissue. But does it have a role against deep infection, like osteomyelitis? Isn't that traditionally muscle flap territory?
That was the traditional teaching, yes. Muscle flaps for osteo because of the high vascularity. But here's another great board prep pearl that kind of challenges that.
Yeah.
Hong and colleagues published a series, Therapy Level 4 Evidence, where they treated 28 patients with chronic osteomyelitis. They did thorough debridement, then covered with ALT perforator flaps.
And the outcome?
Successful eradication of infection, despite the ALT not being a muscle flap.
So wait, this level 4 data suggests a well-vascularized perforator flap, like the ALT, can handle osteo just as well as muscle after proper debridement.
That's what the evidence suggests. It's a potential game changer. You get infection control and potentially less donor site morbidity compared to taking a whole muscle. Huge benefit for the patient, especially someone young like our example case.
That is significant. While we're on maximizing function, what about sensation? Is it worth the extra effort to do sensate-free flaps?
It seems like it might be. There's a prospective study, Therapy Level 2 evidence, that looked at this. They used sensate lateral arm flaps and connected the flaps nerve end to side to the tibial nerve.
End-to-side coaptation.
Yes. And compared to control patients who didn't get the nerve hookup, the sensate flap group had measurably better results on sensory testing.
So it supports trying to restore sensation, not just coverage, aiming for better functional form.
Exactly. Restore what's lost as much as possible.
Okay, let's pull back now. Long-term outcomes. This is crucial for counseling our 25-year-old patient. Salvage versus amputation, what does the future hold?
This is where the data gets really interesting and maybe sobering. The big meta-analysis by Buss and colleagues, Therapy Level 2 evidence, found something striking.
Which was?
At 7 years out, there was no difference in functional outcome scores between patients who had complex limb salvage versus those who had an early amputation.
No difference in function at 7 years. That's counterintuitive, maybe.
It is, but it's a powerful piece of information to share. Functionally, they end up in a similar place long-term, on average.
But the journey to get there must be different, right? Salvage sounds like a much rougher road.
It generally is. The data confirms that. The limb salvage group typically has higher initial costs, way more infectious complications, that was the most common issue, and significantly more reoperations and rehospitalizations.
So more surgeries, more complications, higher upfront costs for salvage, but similar long-term function. Makes amputation sound potentially better.
Not so fast, especially thinking about cost long-term. There's a nuance based on age.
Tell me about that.
A cost-utility analysis by Chung et al. Looked specifically at Gustilo 3 B and C fractures. They found that for younger patients, amputation actually ended up being more expensive over their lifetime
More expensive? How?
because of the ongoing costs of prosthetics replacements, fittings, maintenance year after year, decade after decade. So for our 25-year-old, salvage, despite the rougher start, might actually be the less costly path over his entire life.
That's a critical point for counseling younger patients. What about returning to work? That's often the main goal.
That's perhaps the toughest statistic. Regardless of salvage or amputation, patients with these high-energy, lower extremity injuries have roughly a 50% chance of getting back to work 2 years after the trauma.
Only 50%. Wow.
It's therapy level 2 evidence, a really sobering reality about the long-term impact of these devastating injuries, no matter which path reconstruction takes.
We should probably contrast all this somewhat difficult adult data with kids, though. It's different for them, right?
Oh, absolutely. Children generally do much better. They don't have the baseline vasculopathy or the comorbidities we see in adults. Studies show kids tend to have successful limb salvage, they all end up walking, and complication rates are lower, especially if surgery is done within about 7 days.
It really highlights how much those adult comorbidities impact healing and outcomes.
It does. The underlying health of the patient and their tissues is just so crucial.
Okay, let's summarize the big clinical takeaways for everyone listening. What are the absolute must-knows?
All right. 1. Scoring systems. Useful for initial assessment, but never the sole reason to amputate. Rely on your clinical judgment.
2. Vascular assessment. Intraoperative angiography is your level 1 gold standard for surgical planning. Be ready to assess in the OR.
3. Timing. Early closure seems best for function if possible. But the VAC is a reasonable board for clean, debrided wounds if you need more time. Remember the caveat. Clean wounds only.
4. Flap pearls. The ALT perforator flap is effective against chronic osteo, challenging old dogma. And be very wary of the sural flap in patients over 40 or with comorbidities due to that high necrosis risk.
And don't forget the long-term view. Functional parity at 7 years between salvage and amputation. But salvage means more complications and surgeries up front. However, for young patients, salvage might be less costly over a lifetime. And sadly, only about half return to work by 2 years.
So connecting this back to practice and MOC, keep comparing what you do against this kind of authoritative data. It's always evolving.
Absolutely.
Which leads to a final thought. We see fantastic outcomes in kids near universal salvage, low complications, likely due to their healthy tissues and lack of comorbidities.
Right, they heal incredibly well.
So given that, and considering the high complication rates we sometimes see in high-risk adults, say over 40, smokers, diabetics, especially with options like the sural flap having high failure rates, should we be thinking more about preconditioning these adult patients?
What do you mean by preconditioning?
Could things like prophylactic hyperbaric oxygen therapy or other aggressive protocols aimed at optimizing tissue health before we even attempt complex free flap salvage make a difference? Are we potentially missing a step in preparing the soil before planting the seed of a complex reconstruction in these high-risk adults?
That's a really interesting question. Are we doing enough upfront to optimize the recipient site physiology in these challenging cases before we commit to major reconstruction?
Something to think about before your next complex case. Until next time on The Deep Dive, keep digging into the evidence.